Good afternoon, everyone. We will go ahead and get started. Welcome to the Resuscitation Quality Exchange call. My name is Diana, and I will be your moderator today. Feel free to ask any questions throughout the presentation by typing them into the chat box on the right-hand screen of your computer. Press the microphone at the bottom of your screen, or if you're on phone audio, press *6 to come off mute. The slides and the link to this presentation will be sent out within 1 to 2 weeks from today. I will now turn over the presentation to Cherie Boxberger, our Regional VP of Quality.
Hey everyone, welcome to Resuscitation Quality Exchange. So glad to have you on. A little different because we normally have this one at 8 a.m. Central, 7 a.m. Mountain. So this time we're at noon. So AFib and resuscitation got switched. So glad to have you on. This is the fourth of the quality exchanges we have about our Get With the Guidelines products, and the one remaining is tomorrow and at 8 a.m. Central, 7 a.m. Mountain Time. That quality exchange will be dealing with Get With the Guidelines CAD, coronary artery disease, both STEMI and NSTEMI. And so if you have not yet decided to join that, that's going to be available tomorrow. So glad to have you here. So let me see if I can get my slides going forward. Here we go. All right, here's what we're going to talk about today. We're going to kind of look at last year's year-end performance. I know for most of you that your resuscitation processes have been, to say the least, challenging during the first quarter and even into the second quarter related to COVID. So we're just going to look at our data for 2019. I want to show the recognized sites, those of you who've been recognized for your performance. There were a few updates to our platform, which we'll go through. And then mostly today, we want to be able to share with you the many, many resources that are available related to cardiac arrest, all sorts of resuscitation elements, CPR, intubation, airway management, so on and so forth. And we'll be going through some of those resources. So it's an interesting time in healthcare, and certainly we are appreciative for the extra work you're doing as it relates to providing high quality resuscitation. So we'll hop on in here. You know, our goal is always to improve survival to discharge. And certainly we look at many of these numbers through Get With the Guidelines Resuscitation. So this is an annual update. This is the year-end performance for the 6 states of the Southwest. Just as a reminder, they're there at the bottom: Arkansas, Colorado, Oklahoma, New Mexico, Wyoming, and Texas. And all of these went up, just so you know. Decreasing that time to defibrillation for our shockable rhythms, making sure that that is done in 2 minutes or less from the time you identified the need for CPR, and that number has eked up. This is for all sites. Certainly we've done a good job at getting our patients into the right area. 97.5% of our patients are in an area where they are monitored and witnessed. Looking at the time to epinephrine, which is one of our achievement measures, which continues for our non-shockable arrest to be high. And then the tricky one, which is really a documentation issue, confirmation of airway. And we have increased that to 71% when you look across the board. Now, we know that in Q1, and Natalie, who's joining me today, Natalie Navarre, will talk about some of the things that have been done differently because of trying to avoid aerosolization during COVID. So we expect that this particular measure in Q1 and 2 may not look as good. We're not able to do some of the things that we've done in the past. So we'll talk about that a little bit. And of course, many of you are already participating, but we certainly know that we have to have high quality CPR whenever we're trying to improve survival to discharge. And many of you are already participating in RQI, but if you're not, let us know, and we'd be glad to show you what that program, Resuscitation Quality Improvement, which is a CPR competency program that actually ends up saving most of our hospitals money on their CPR education. If you haven't seen that, let us know, and we'll be glad to get you up to date. I did want to talk about all of our facilities that were recognized, and you have not received your packets yet, but you'll get those within the next week or so. but I wanted to go through our hospitals that have been recognized for in 2020 for their 2019 performance. And so I'll just kind of flip through these as we go. You'll be receiving an awards packet that has your press release, the various widgets you can put on your website, so on and so forth, as well as your certificate and the opportunity if you would like to have a virtual award ceremony. Unfortunately, this year, we're still not able, you don't want us in your hospitals, and we're still not heading out, so this will be a year for virtual recognition, but that doesn't diminish how much work that you've done and how proud we are of all of you who are at recognition level. Real quick, want to talk about, well, let's just stop right there. Any questions or anything you have as it relates to, and I'll go back a little bit, as it relates to the achievement measures and perhaps things that you have done or challenges you've been having or how you're making the airway confirmation work. I know we've had folks who have been using X-ray and all sorts of things. Any comments as it relates to these achievement measures, the ones that are in green here on my screen? And you can type them in and Deanna will read them, or you can *6 or come off and talk to me and tell us what your experience is more recently, because this is 2019 data. Anything written in, Deanna? I'm going to assume no. All right, we're going to hop on in. Anytime you can pop in your questions. PMT, and that's patient management, our patient management tool. That's where you put your data. We have added in the 6.3 release, you will see that you are able to report if there was an active or suspected COVID-19 diagnosis in the past 2 weeks of this admission, yes or no or unknown. You're able to then look at the diagnosis test, that it was suspected or confirmed, and if it was confirmed, the date, time of that diagnosis. So this will be really some important information. We have added these data elements in stroke, heart, in all of our modules, heart failure, AFib, all of them, so that we can begin looking across these patient groups to study the impact of COVID. And you'll note that we also have the Get With the Guidelines cardiovascular COVID registry, which now has over 100 hospitals participating and several thousand patients. So really the work that we're doing, as we're learning more and more about COVID, we will be able to get it from this information you're entering. The other thing that you have access to is your risk standardized reports for 2019 are there. And if you recall, this is one of the special features of Get With the Guidelines resuscitation participation, is that you get this risk standardized report once a year. And just as a reminder, there to the left, you see that these are the types of things that are built into that risk adjustment. Age, of course, whether or not they were in a monitored unit, if a patient has other issues related to low blood pressure prior to cardiac arrest, sepsis, so on and so forth, if they were on a ventilator, of course. So it takes all of those things into consideration, and then you are able to pull up your own hospitals, and you'll see there, you go under reports, configure reports, and it's down under advanced reporting. You may be familiar with pulling this report off of your front page, and it still is there as well on your community page, but it's been integrated into the reporting section. So if you had all the data available, if you finished your data by the end of February, you have this report, and it will show you which quintile you are in. You may have noticed that we had some of our folks who got plus, and I'll pull out a few of them. I'll just go ahead and go through here. So Children's of Dallas, Medical City Dallas, St. Francis, CHI St. Luke's in Houston, and the Methodist Hospital System, as well as UTMB on their pediatric. The plus comes from your risk-adjusted performance. So that's how you get plus. Any questions or concerns or anything you'd like to talk about on the risk-adjusted or that you have questions about? And if you, you recall, this is built on Dr. Paul Chan's work out of the Mid-America Heart Institute. He also works on our Get With the Guidelines resuscitation clinical lead team. And so this is a published study that was able to use this index in order to get a risk measure. All right. Real quickly, thought you might be interested. This is how the American Heart Association breaks up our regions, and so I thought you'd be interested. This is of Monday, the number of COVID-19 cases in our various regions. So certainly the Northeast, many large metropolitan areas there. But I think it's just an interesting way to look at that. And we have the link here if you'd like to break it down in some other ways. Now, I want to remind you, and we'll talk a little more, that there is a wonderful compendium. This is being added to every day. I would highly encourage you to go, and you can search American Heart Association COVID Compendium, and this will come up. And this is an old copy of that page, but there are many, many COVID-specific resources there. Everything from related to stroke and assessing stroke patients to heart failure, all the way through the stuff we're going to talk about today as it relates to resuscitation. So many good resources, and as it says, you know, videos. We've got suggestions as it relates to CPR there. Many good pieces of information. And with that being said, I'm going to ask my colleague, Natalie Navarre, who is a registered nurse as well as comes out of the NICU setting. She is going to introduce a few of the tools that are available on the COVID-19 compendium. And so, Natalie, I think I'll just go ahead and move your slides forward. That'll be easier, but go ahead and come off mute, and we'll move along to some of the information you have to share.
Great. Thank you for that, Cherie. Before I take over, does anyone have any questions so far? All right, great. And can you hear me fine, Cherie?
Nice and clear.
All right. So as Cherie said, I'm a registered nurse coming out of the NICU setting. So I am learning about adult resuscitation just as much as you guys are. We hosted a really fabulous webinar on patient resuscitation in the COVID-19 environment. This was led by three MDs, Doctors Edelson, Flores, and Nadkarni. And they wanted to talk about basically the impact that COVID-19 is having on both patient care in the coding environment and also provider safety in the coding environment. We, of course, cannot have one without the other. As you can see here on the slide, specific topics included CPR, airway and ventilation, as well as ethical considerations. The basis of the webinar was questions submitted by AHA employees as well as you and your colleagues. So it was a fantastic discussion with a lot of agreement. And the link is right there where it says watch the webinar. You of course can't click on it now, but we'll be sending out the slides within the next couple of weeks. And if you would like to watch the webinar before the slides get to you, just email one of us and we will happily send you the link over. It's a great one. So Cherie, go to the next slide, please. I wanted to summarize the webinar for you guys. The main takeaways are on these next two slides, and I do apologize for the wordiness, but this was all really important information. The first thing that was discussed was code room considerations. Due to PPE shortages, as well as, of course, emergency situations, you know, the number of team members in hospital rooms absolutely needs to be limited. If you all have been in a hospital coding situation before, you know that usually there's 700 people in a code room, and you're kicking people out. Now we absolutely cannot have that in a COVID situation. So in trying to figure out configuration of the coding situation, the doctors suggested that we aim for fewer than 8 people in that code room. And that's broken down as is laid out here: 1 to 2 people at the airway, 2 to 3 people for compressions, because you're going to have to cycle through. 1 person needs to be running the code. Now that person may be able to be out of the room, using an iPad to put in orders and such. That's kind of up to the facility. And then 1 person at least to be pushing meds. So that gets you fewer than 8 people in the room. Almost everything else can be sent out of the room. You can have the pharmacist out of the room, keep the crash cart out of the room. That's going to be a huge vector if it's in the room. You can keep the recorder at the door in PPE, so that they're not in there. They're still, of course, using PPE, but the recorder has to be as close as possible. Another suggestion was having PPE kits reserved for the code team, so that when they go to open that cabinet, they're not looking at an empty cabinet, right? You have ones that say, no matter what, these are for the code team. A third really important point is to consider that everybody on the code team is COVID exposed, which, as we know at this point, given aerosolation, means that probably everybody on the code team, assume that everyone on the code team has COVID. That doesn't mean they all have COVID, but just assume that they do, and treat it as such. And then people were asking questions about mechanical chest compressors. Given that adds 2 to 3 people to the code room, should we be utilizing those more? And the answer right now is no. Coding situations are so it's such an emergent situation that only if you're already using and comfortable with mechanical chest compressors should you be using them. So there's no recommendation at this point to change procedures. Moving along, point number 2, aerosol generation and ventilation, which goes along with every point in here. But basically, aerosol generating procedures are so many, right? We're looking at CPR, intubation, any positive pressure, including bag and mask. And some of these are potentially, quote, worse than others. The moment of intubation is highly aerosolizing, and it's especially dangerous for the person intubating. That leads into the next point that, in the hospital, your priority is the best, fastest, earliest intubation. And of course, adult-wise, you're looking at with a cup tube, and in every age group, a closed circuit and a filter. In the NICU, we don't always use cup tubes because you just can't. You don't have enough airway space. So, there are situations before COVID that you're getting a new transport nurse or someone in, or a resident to practice intubation. This isn't the time for that. This is the time to push them away and say, hey, who's around that has the most experience intubating? You're in here, do it now. So you really utilize that clinician that has the most airway experience, whoever that might be in that situation. If your intubating clinician is comfortable with it and has used it frequently, video laryngoscopy can be a great way to keep the clinician away from the patient's mouth. There are also some really cool things I've seen lately involving these plexiglass kind of boxes, and the clinician just puts their arms through the holes in the box and intubates right there, and that of course keeps the aerosolation from hitting the clinician. As you generally want to do during coding, you want to pause your chest compressions to limit splashing. And then, unfortunately, people are running out of HEPA filters, but as supply allows, pop a HEPA filter on anything you can that has an exhalation valve. So the exhalation valve of your ET tube, your bag mask, your vent, etc. And I know, again, as supply allows, that unfortunately is not a given right now. And then last point here is that as far as out of hospital, if the patient is presumed cardiac arrest, begin hands-only CPR as you give EMS more time to prepare. Now, all of this being said, this is all very context specific. We know that. We know to take all of this with a huge grain of salt. In COVID, as I have written here, most arrests are hypoxic respiratory failure. So it's so important that you're limiting time without adequate oxygenation. Now, going back to talking about hands-only CPR, we can absolutely assume that there is some air exchange during CPR. I'm not sure if we know exactly how much that is, but there is oxygenation happening during CPR. One of the physicians on the webinar was a University of Chicago physician, and she mentioned that what they use during CPR is they pop on a non-rebreather mask to the patient and put a surgical mask over that non-rebreather. Therefore, they can ensure a little bit more oxygenation, prior to airway establishment. All right, any questions before we go to the next slide? All right, next slide, Sheree. So prone CPR in the adult world, they're realizing that prone positioning can increase oxygenation pretty significantly. And prone CPR, the ruling is that it delivers sufficient pressures. So things that you're looking for in prone CPR, super high risk of ET tube dislodgement, whether you're delivering compressions, flipping the patient, all of those types of things. So again, as supply allows, that's going to be, our new catchphrase with COVID, assign one person simply to hold the ET tube in place. You can be doing the best CPR in the world, but if your ET tube's out, good luck with that. And then if your patient is prone and they're not ventilated, flip them immediately for airway access. Next up, this is definitely an ethical question, but many people have the question about universal DNRs for COVID patients. And the webinar was over a month ago, and so of course things have significantly changed since then. And I feel almost like this question made a little bit COVID when we were only seeing when we were mostly seeing older patients with significant comorbidities, but even at that point, in short, the answer is no. We're not looking at universal DNRs. COVID is not an automatic death sentence. Again, very much depends on comorbidities, age, all of those factors. And then a really important point to remember that we do forget is that patients may arrest and they happen to have COVID-19, but they were going to arrest anyways, from arrhythmias, other cardiac etiology. So, a patient with a shockable rhythm, even if they're already vented in the ICU, very sick, has a much higher survival rate than a patient with a non-shockable rhythm, no matter where that patient may be. So, in places like New York City, ethics experts absolutely have been trying to determine if there's a way to categorize futile versus not futile patients. And this is going to keep evolving. It depends on resources, risk, data. We know now that COVID patients are younger and sicker, and they're having more, they're developing more sequelae from COVID. So we can't make that determination quite yet. But if evidence-based information becomes available, AHA hopefully will be one of the first to disseminate, more of that quote futile versus not data. And probably the most important point here is that if any kind of universal DNR comes out or anything related to that, it's got to be crystal clear. You can't have your people on the front lines guessing game time what is going on, just guessing game time. Oh, COVID, DNR, right? So, so that, maintaining open communication, open lines of communication about these processes is of course priority. And then lastly, changes for lay people. Not right now. The one new recommendation that we are making is a face mask or a barrier for both the layperson performing CPR and the person receiving CPR. So we still want a layperson to start CPR ASAP. Secondly, an AED is not aerosol generating. And third, most arrests still have cardiac etiology. So someone that's out jogging that arrests, again, most likely cardiac etiology. Before I said most arrests in COVID are due to hypoxemic, respiratory failure, but that's if it's only, that's pretty much if it's only COVID. If it's exactly due to COVID, that's probably going to be your issue. But any other arrests, again, likely have cardiac etiology. And lastly, the number that we used to use was that 70% of arrests occur in the home. That is likely a much higher number now that people are avoiding EDs, avoiding calling the hospital. So greater than or equal to, at this point, 70% of arrests are occurring in the home. A household member who's already been living with someone who has COVID-19 has very little additional risk of contracting COVID by performing CPR than before, simply by living in the same household as a COVID positive patient. Whew, there we go. We'll just glance at the next slides. So if you go ahead and go to the next slide, Cherie, we have these available. This is the updated ACLS algorithm for suspected or confirmed COVID patients. A lot of it is what I just discussed, and most of it simply adds PPE. Next slide. BLS for adult cardiac arrest for suspected COVID. Same thing. I'm not going to read it all the way through, but again, don PPE, limit personnel. Next slide. BLS for pediatric. Same as the above. Next slide. And pediatric cardiac arrest algorithm. Again, don PPE. That's that. Next slide. Is there another one? And then this, we didn't talk about ECMO, but this kind of goes back to limiting the number of people in a code room. This is looking at how to configure people around an ECMO patient in the setting of COVID-19. I found it interesting. Next slide. And I will give it back over to Cherie, but I am happy to answer any questions after that presentation.
And as we're looking down, see if there's any questions, but I do want, let's see, Natalie, go ahead and mute and we'll see if, okay, and then we'll come back with you if they have questions. Is that some of you are having difficulty finding places to put these things in to get with the guidelines. So, for instance, the prone CPR doesn't really match up the type of CPR. If you're unable to use the methods that are there for checking the airway, we don't have the options to put in there. So just rest assured, we're asking you to put as much as you can in there, but sometimes it's not going to match because we've changed a few things that wouldn't have normally been there. So Deanna, any questions in the chat box, or if anybody wants to just pop off and ask Natalie some clinical questions, she's available. All right. Well, you may have seen this. This is now, we're excited because Don't Die of Doubt actually started, this program started in the Texas area, but we have a whole national effort of Don't Die of Doubt, which doesn't have it on here, but making sure that we can get the message out that it is safe to come to the hospital. It is safe to call 911, that our healthcare professionals, both pre-hospital as well as hospital, are prepared and ready to take care of them and keep them safe. And so we're continuing to study the number of heart attacks and strokes have gone down as we look at our emergency numbers. And so we want to be able to do that. So what we have for you with this link is an opportunity for you to use some of these and to be able, either for your hospital, for you personally, for all your employees, to be able to use these resources and put them on LinkedIn and Facebook and Twitter and around the hospital to make sure that the public understands that staying at home is not the right decision when you are experiencing symptoms of heart attack, stroke, and to be honest, our heart failure patients, who I work with that module as well, who are very hesitant to do some of their follow-up because they're afraid and they are high risk. And we're seeing many hospitals setting up drive-through labs and doing telehealth visits and so forth, but we need those emergencies to continue to use 911, to continue to use our emergency departments. So when you get these slides, click on there, and you can feel free to share those far and wide. And there's a bunch more resources on oxygenation. There's actually 3 different videos that go through specific as it relates to oxygenation, airway management, ventilation of these COVID-19 patients. So, and their video education there. So many resources available. Now we have zipped through here today and in 30 minutes, and we don't want to keep you longer than you need, but we want to be able to see if you're having issues as it relates to get with the guidelines, if there's other education you need. If you have any questions about awards, feel free to type those in and Deanna will read them, or just *6 or come off mute and throw them out here. And we may have a small group today, lots of people doing a lot of different things, but we do record these. And so when we send out the slides and the recording, feel free to share. Natalie and I were just discussing this morning, how important this information is across the different diagnostic areas, a gift across the different floors at your hospital, because the people with the heart attacks, with coronary artery disease, doing STEMIs and NSTEMIs, this still applies. To the strokes, this applies. To your serious heart failure patients who may be hospitalists, this still applies. So please share these resources, because usually we're talking about our registry and the standard code situation, but right now we need to really spread this information as far as we can. And I thought I might really quickly just show you the current compendium. Let me go back to the, sorry, just close your eyes. I'm probably going to make you dizzy. But I thought I might just look up, and now I think we can do this. I'm taking a risk that you'll be able to see this. Deanna, can you see that? Or am I only sharing PowerPoint? Okay, I'm doing the wrong thing. Yeah. I'll do it in just a second. I just got to share the web browser so I can show you. Okay.
I see it now.
Let me get over there. Where were we here? Here we go. Okay, can you see that, Deanna?
I sure can.
Okay. All right, because I want to encourage and just show you real quickly, this is today's version, obviously live, for our AHA compendium. So just a one-stop shop, and you will see that we have the dates that things are on here. Here's the issue related to guidance for stroke centers when related to your COVID treatment teams. I'm just going to kind of go through here. We're starting to see the different things that are in circulation. You know, we've been hearing a lot about this inflammatory response syndrome, that is really what's causing the difficulties with COVID. So again, from circulation on June 19th, way back, there's still very good information that's a little older. AFib, we've got information, the guidance on that. The STEMI system of care. We know in China that the systems of care we're working very hard to make sure that that time to PCI or symptom to PCI is very fast, definitely under 60 minutes, 45 minutes in some cases. But during COVID, of course, that's been way spread out. Here we have more as it relates to heart failure as a result of COVID, and then pediatric ICU issues. So anyway, I would encourage you, here's a bunch of podcasts. Some are from around the world, women and heart disease, many nice resources there. We also have specific tools like heart failure and what you need to know for COVID that are on here. And real quickly, some of the measurement side, comparing COVID-19 with the flu, because people are talking about that all the time. Predictive modeling, because clearly our original modeling wasn't great. So anyway, just really encourage you. And then real quick down here, this is the COVID-19 data challenge. that we have out there where we really want to make sure through our precision medicine platform that we look at who's getting care as it relates to COVID-19, the differences in that, and be able to collect some data. So anyway, lots of great info. Deanna, any questions that have come in?
No questions. And again, you can type them in the chat box or come off mute by typing, pressing *6.
And I'll pop back over to my PowerPoint and go to the end. So as always, we are here. If you need some of these resources sooner, you don't want to wait for the slides, just email us at SWQuality, tell us who you are.
Sure,
some of you know your quality director. Oh, you can't see it. I got to change it. Sorry. I'm getting used to how I have to switch the types. Sorry about that. Google, screen 1. Here we go. Oh, that's not it. Yeah, that's it. How about that? Oh.
It's coming up. There you go.
Okay. There's our email, swquality@heart.org. Or if you know your director of quality, just pop out to, I'll say her, because at this point the Southwest folks are women, and let us know what you need. If you need a resource, let us know. If you need any help as it relates to training, if you have to change abstractors, whatever happens, please reach out to us. But we are so thankful for your life-saving work. This is a very important element. It's important to continue to provide this care during this pandemic. And so we just want to be able to provide the information you need so it's at your fingertips. So one last look at the question box, Deanna.
No questions thus far.
Right. No worries. We appreciate you joining us. We're going to give you a few minutes back in your schedule, and if there's anything we can do, we would be glad to do it. And if you're interested, join us tomorrow morning for the coronary artery disease quality exchange, and you can just email swquality@heart.org if you want that meeting invite. And so thanks to Natalie Navarre, to Deanna Ramirez, and I'm Cherie Boxberger, and we're glad you joined us, and we will see you next time. Thanks so much.
Thank you, everyone. The slides and links will be sent out to you 1 to 2 weeks from this presentation. Thank you. Have a wonderful day, everyone.